medicine. We have problems in waiting times and delays, which are very serious. My wife had a medical problem yesterday. Was told she had 2 months to wait to get resolved. Luckily, she's a fighter. She went in and she got seen, but not good. We have problems in waste. You will all watch in your daily work stuff, and you'll say, "Why do we do that? What's going on here? Why is this? Why are we not focusing our energies where they count instead of wasting our time?" We have problems in equity, which are the big, big, big issue right now, which I'm going to focus the rest of my remarks on. So look, my world of work outside being a clinician has always been quality of healthcare. And by the way, uh, advertisement, you guys all and women should all be on ihi.org/open school, the IHI Open School, which we've worked with for 10 years now. There's 1 million young professionals on the Open School, taking courses, part of local chapters, working all over the world on mobilization, 100 countries, 1,000 chapters. So join the Open School to try to build your skills in this improvement. So that's been core to my career. But when you really get honest about it, and you say we're here to help people feel better and reduce suffering and illness, we would, as scientists, look at causes, and that's what leads us to social determinants of health, which you've all been studying in your professional preparation, and you know what those look like, the things that actually make us sick. Healthcare is a repair shop. It doesn't cause health. It repairs insults to health. And the list of social determinants is quite long. It includes, very importantly, the nature of supports for very young children. The early years really shape later life in very powerful ways. I just heard a lecture yesterday that if I had time, I would show you slides from it about childhood opportunity scores in this country. And there are children, many millions, tens of millions of kids who grew up with constant stresses in their lives that will erode their health as adults. As to the education system, strong education systems are associated with better health. With workplace conditions, especially meaningful wage for everybody. Do you know there are 1.4 million healthcare workers who have no health insurance? There are nearly 2 million workers and children in healthcare who are on Medicaid because we pay them so little. It has to do with the situation of elders in our communities. What are they lonely? Are they lost? They get sick. And it has to do with community infrastructures like transportation, housing, food security. 40 million hungry people tonight in America. 17 million kids hungry tonight. 600,000 or 700,000 people chronically homeless tonight. These are causes of illness. Michael Marmot, the great epidemiologist in England, in London, Michael says that these are the causes of illness, social determinants of health, but then he calls there's the cause of the causes, and his term is fairness. That is, if we're a society that makes sure that people aren't left out, that kind of evens up opportunity, evens up even income better than we do, they're healthier societies. Our tax code, for example, is highly redistributional the wrong way. It redistributes wealth from poor and working people to quite wealthy people systematically. Healthcare is regressive that way. Healthcare redistributes money from people of disadvantage to people of advantage. That Michael Marmot predicts will produce illness. So you might say, okay, we're healers. Why don't we work on causes of suffering? And we don't. Not just we professionals. We, this American society, doesn't. Even under Democratic administrations, we have been timid about food security and housing security. We could eliminate homelessness in this country. It can be done. It's been done in 15 or 20 cities already now, thanks to the leadership of Roseanne Haggerty and her group. We know how to eliminate homelessness. We surely know how to eliminate hunger, but we watch it. Inequity would be dealt with through social policies that are somewhat redistributional. Not we don't have to take everything away from people who are wealthy, but we can have a commitment to seeing that people with a lot help people with a little, as they probably want to, but we need government to help us do that. So the frustration that leads me to this kind of port of arrival is that we have known about this for so long, and haven't fixed it. Why? How could it be we would tolerate these causes, which are known and remediable, for decades, in some cases centuries, and not fix them? And the answer is, I don't know why. I just don't know. There are certainly nations all over the world that have a much stronger commitment than we've had to fixing causes. I'm not talking about kind of some absolutely even redistribution, but just say, look, we have hunger, let's stop it. We have homelessness, let's stop it. We have opioid epidemic of 60 or 70,000 deaths a year. Let's do it. Let's stop it. Let's make promises to ourselves as communities, and we haven't done it. I guess economists would point to economic circumstances. One favorite, point of blame is the fee-for-service healthcare system, where we pay so much for activities in the repair shop that we don't really have money left over for the other stuff. Healthcare confiscates opportunities from government and private sector actors because it takes and takes and takes. Because it's noble, we want to have healthcare, and the prices go up and we take more. Others would say maybe there is an underlying meanness in society, that we just are not equipped as a nation to be compassionate as a matter of policy. A pretty jaded view of the human nature. And by the way, it assumes that there are an awful lot of people not like me, not like you out there. Somehow these different people that don't care, even though you care. I don't know, but that led me to what Ollie was referring to, which is this hypothesis that I guess we have to check back on our moral vocabulary and ask pretty deep and important questions like, what kind of society do we want to be? What kind of country do we want to be? What about compassion? What about helping people in trouble? What about a sense of solidarity, that we are in this together? Uh, what about inclusion instead of exclusion? Doesn't this describe the community you want to be? An inclusive, compassionate, helpful? Does mine, and yet we're not. And I think we have to remind ourselves that these have moral foundations, not necessarily religious foundations, but something important to touch base with here. In my paper, I quote Immanuel Kant, learning only later, by the way, that Kant was a vicious racist, a terrible, terrible man when it came to racial prejudice and misogyny, but also a philosopher of import. And I quote one of Kant's phrases, which is widely known, which is, he said, two things fill me with unending awe: the starry skies above and the moral law within. And that's about the best I can come up with, which we check what we care about and then build a country around that, a community around that. That led to the list that Ollie quoted, because I said, well, hold on a minute. If we really wanted to work on causes from the viewpoint of compassion, solidarity, caring, what would we address? And Ollie read you the list in the paper I wrote. That was pretty random. I mean, it was just stuff that seemed important to me to note. Join the human rights community worldwide, commit to healthcare as a human right, solve this vicious, vicious criminal justice system we have today. It is highly destructive. End the horrors of this of immigration policy that is not compassionate or understanding. Address climate change, which is going to hurt us so badly. Me already, but my 7 grandchildren, soon to be 8. I have one arriving November 15th. We're destroying something very important, and it is health also, because it's going to do its work through climate refugees and droughts and storms and climate wars. I talk about hunger and homelessness directly. Those two just always have seemed to me so accessible. If we just decided nobody hungry, nobody homeless, just decided. And then the institutional structure for acting as a proper government means agencies that are supported to do their work and to root their activities in facts and science, the best possible level, expert level, and the vote. At least in theory, we support the idea of one person, one vote, but that's not what we do. There's not just terrible voter insecurity right now, and it's going to play out between now and November 3rd in ways that are really pretty shocking. But there's the Electoral College itself, which is a highly undemocratic setup if democracy means one person, one vote. The vote of a person in the United States in a small rural state today in the election of the president counts 70 times, 70 times the weight of a vote of a person in an urban state. We haven't set it up for that kind of democracy. So when I write these down, which I call the consequences of thinking about moral determinants of health, I arrive at a really, really uncomfortable place for me and for you, because it's like, wait a minute, what am I supposed to do? I'm supposed to end climate change. I'm supposed to end homelessness. I'm supposed to invest in human rights treaties. I'm supposed to fix the criminal justice system. Me, you know, David, signed up to be a doctor. I didn't sign up to do that. Yeah, I know. And that's the conversation to have, which is, should we, will we, can we be engaged at that level? Or, and I don't think this is a rhetorical question, do we return to our consulting room, close the door, and help these very, very troubled people that come to us for help, and we want to help them, and maybe that is our work, and that's it. I don't think so anymore, but I totally respect people that do. So Ali, Maddie, you invited a conversation now. You're going to pull some lever, if you haven't already, on November 3rd that has to do with this, because the different candidates you're voting for will have different positions on this axis. They will or will not want to end climate change. They will or will not be willing to be courageous about criminal justice or about human rights. And you may, I'm not telling you how to vote, but that is what we're going to be voting about. But November 3rd will come and go, and after that, we have a society to build one way or another. And the question is, what's your job in that? Can I stop there, Ali, and welcome a conversation? I hope that was okay.
Absolutely. Thank you so much, Dr. Berwick. We could probably all just sit here and just keep listening for the rest of this town hall if we wanted. I guess I'll start this conversation going with, you're describing the roles that we signed up for. And I think I've heard you say in the past somewhere, and I'm paraphrasing, this may not have been the role that we signed up for, but the roles have changed or should change, as we would also argue.
So the job got bigger.
Yeah, it did. And it reminds me of the quote from 1848 from Rudolf Virchow, claiming that physicians are the natural attorneys of the poor and social problems fall to a large extent within their jurisdiction. And so when I think about whether it's expanding the role that we have as within the healthcare community, or affirming some of the claims that go that far back, how do you envision that being done? Because sometimes we'll have like-minded people here, for example. Is this a training issue? Is this a cultural issue? How much of this is the medical regulatory complex that and in terms of the types of physicians that we're developing versus perhaps even earlier interventions?
Yeah, it's in this journey, I become familiar with Virchow's work on this, and it's amazing to read his writing. It's so relevant to now, and he does put the same question I am. He thought of it first and better, but so what is the opportunity? I'm not sure. I hope maybe people in this conversation in the town hall will raise some questions, but here's just to give you a framework to think about it. There is first personal behavior. So each of us is a physician or nurse or healthcare professional and a citizen and a member of a community. And so you get to act from that second role, from that community role, the citizenship role. And I'm urging, yes, we have to. I think we need an engaged citizenry. I don't think the seat of bystander is available anymore. When I came of age in the 60s, in 1960s, in the civil rights era, and the radical civil rights left at that time famously avowed, if you're not part of the solution, you are part of the problem. And we're kind of in that position right now. Silence is not available. It's not true bystanderness. It's support of the status quo. So this means, what does it mean? It means you vote. It means you speak up in the collectivities you happen to be members of. It means you write, and physicians especially have voice. People want to know what you think, and you can write about it. You join. For example, my biggest thing right now, for reasons I cannot explain, there's so much I feel now that I can't explain, is criminal justice, because the more I study it, the more angry I get. In your whatever, I don't care what town or city you're in, there is a criminal justice reform program somewhere. There is some civil society group has formed to try to get compassion and healing and respect and anti-racism back into criminal justice. Join them. You can be part of that. You can show up at their meetings and become an officer in their groups and so on. So I say, to me, it's speak, write, join, and vote, and that's the individual list. Second, you're going to be part of corporate collectives, hospitals or physician groups, and I urge you to seek a voice and leadership there, not with anger, not with arrogance, but with passion about what you care about, and urge compassionate, progressive participation by these organizations in the communities they sit in. There are models for that. There's the anchor organization model now. It's a national movement to get hospitals to use their money in supply chain management and purchasing and hiring and construction and philanthropy. Use it locally. Find the areas of your locality that are in trouble and go there. It's sponsored by a group called the Democracy Collaborative, and I think there are now 24, 25 organizations in the anchor institution movement. Speak up about that. Maybe you could get yours to become one. As a physician or nurse, you're going to be engaged in the organization, and you can be not silent there either also. And then there's the political mobilization side, which you all are. AMSA is doing a wonderful, wonderful job with voting now. But I think maybe mobilization, I hesitate here, could be part of the training of professionals. I've been working a lot with Marshall Gans, who's this amazing expert on mobilization, and he's taught me so much. And right now the IHI Open School is working with him, so you can join a mobilization community. None of this is easy, but look, if we're not involved, who will be?
Thank you, Dr. Berwick. So many of the issues that we know about and their causes have been long-standing, and many of them have now just been amplified in recent months by the pandemic. So we have the first question that ties directly into that from Zareed.
Thanks, Ellie. And thank you, Dr. Berwick, for taking the time to speak with us today. So I wanted to know, what kind of healthcare system do you think would have been best able to handle the pandemic? And what steps can we take in this country towards setting the path for that ideal system?
Thanks, Zareed. Is it illegal for you guys to call me Don, or is that, you don't do that, I guess, is in AMSA? Please feel free. Zareed, there's a couple levels to answer your question. It's a really interesting area of inquiry. First, if just in terms of what structures of organization of care have thrived, have been not more than survived, been able to do well during the pandemic, the answer is generally healthcare systems in which payment is for population care. The current jargon is, an alternative payment model, an APM. But an organization that's sort of getting paid to take care of a population, not fee for service, those have done okay. Some of them are accountable care organizations, and I'm happy to talk more about the wonkiness of that if you want. A place like Kaiser Permanente, which is, it gets paid to say, here's, 8 million people or whatever it is, take care of them, please. And then when COVID hits, no, the doctors keep getting paid. The place has the money to put where it's needed, and they're not trapped in the loss of volume. Volume doesn't matter to them. It matters is meeting need. And so that we learned that. I will say, and this is quite political, but I am on record supporting a national health insurance, a single insurance system that would be national government payment. Obviously, if that were done, and it was done through a population payment to the healthcare, would have been much more survivable right now. And in Massachusetts, where I live, over 20% of primary care practices are now saying they may have to close forever. That wouldn't happen if they weren't hooked on the fee-for-service system and weren't the payment system weren't so complex. I would say overall, whether it's a national insurance system or not, when you get paid for population care, you survive COVID better. Second, of course, are countries and organizations that invest in strong public health systems that can mobilize contact tracing or patient or population education, protective behaviors. We have such a weak infrastructure for public health. Every state public health department is starving for funds, and so we imbalance. We supported the curative system, not the public health system. Other countries that were able to mobilize public health have done far better. Watch what's happened generally, say in Singapore or in uh, in uh, in Vietnam, uh, in countries that have put public health central to the way they're organizing, which of course takes government investment. Whereas in this country, we've starved public health for a century.
Thank you so much. In line with discussing a little bit about the COVID-19 pandemic and the response is also the issue of vaccines. So the next question is actually coming from our Global Health Committee from Nadia.
Hey, Dr. Berwick.
Hi, Nadia.
Hi. Yeah, so I represent the Just Medicine campaign with AMSA, and we're centered around healthcare prices and them being fair and just. And so our question is about how does the US not being a part of COVAX, the Global Vaccine Alliance, how does our not being a part of that kind of affect our economy and our international relationships? And then to back that up, kind of what will be some of the challenges of a fair global COVID-19 vaccine allocation?
Well, okay. Not being part of the global regime for trying to develop vaccines together and share in a global plan for their use is, I'm trying to find gentle words for it. I can't. It's stupid and vicious. And what it does, it cuts us out of the connectivity could have to a very capacious global endeavor now to develop all sorts of vaccine possibilities and have access to them. We're kind of like, it's a go it alone posture that fits neither the modern economy, the modern sensibilities about our interconnectedness, nor the moral determinants we talked about. We should be part of an international process to figure out how to get the vaccines where they will do the most good. So I'm not a fan of what we've done so far, and what it does is it does isolate us. I this week I've been on a number of global meetings, with, in one case, a European group, a consortium that is working on COVID care altogether. That I didn't hear the U.S. mentioned once. Wasn't mentioned. Why we've made ourselves irrelevant to that, and it's very short-sighted. It also doesn't allow us, by the way, to step up and do what we should for the the countries that are suffering the most, and will suffer the most in the future. Luckily, so far, the global South and Africa has been relatively spared. I mean, South Africa's had some serious problems that other countries have, but overall, surprisingly, so far, it may break out. Latin America, on the other hand, is a very bad hotspot, and we should be thinking hard about helping in the middle-income communities there, and we tie our own hands. So it's a reputational issue, it's a fairness issue, and it's really lacking self-interest, as you probably know. Since Nadia, you mentioned it, I will have to go back to one other. I mean, I'm so irredeemably wonky that I have to get into pricing. You mentioned price, and this is something important for all of you as young professionals to realize, that there's been a lot of good research in the past 5 or 6 years trying to understand why American healthcare is so inefficient compared to other countries and relatively ineffective. We spend more than almost twice per capita as the next most expensive country, which I think is Switzerland. Maybe we're 40% more than them. And our health status, as you all know, you by now you know the figures. We're like 40 something in rank in life expectancy and infant mortality. International rating system last month came out with global ratings of health system performance. We were 93rd in the world at nearly double the cost. So researchers like me were really interested in cost, and it turns out, I think we're pretty well, the evidence is really strong now. It's price. The driver of this excess cost is insane pricing compared to the rest of the world. It does include pharmaceuticals, where our prices are just out of sight compared to what other countries pay. It also involves equipment and procedures and things like that. So if we want to get back into the mainstream and a proper allocation of resources in our country to health and well-being, we're going to have to work hard on prices. I know you and your group already realize, Nadia.
Thank you. We talked a little bit about the healthcare systems, and currently there's a number of threats coming to the Affordable Care Act and the existing U.S. healthcare system. So our next question is dealing a little bit on that topic. I'll hand this over to Maddie.
Thanks, Ollie. Yes, actually, especially considering the upcoming Supreme Court case, I think that this is a particularly relevant question. But the Affordable Care Act has received multiple attacks since its conception. What will the future hold for the ACA, taking into consideration today's political climate? And what would a repeal mean for patients and for physicians?
Do I have screen sharing up rights here?
Yeah, I believe so.
Yeah, let's try it out.
I'm going to show you something and answer. So, okay, let me deal with it first, and I want to show you something that will help you think it through. So what the facts you're referring to are that this administration has over and over again attacked the Affordable Care Act in part or in whole, and now there's cases reached the Supreme Court, which will be argued on November 10th, 1 week after the election, and then I don't know quite when the decision will come down. I assume in the early spring. Maybe one of you knows. And the argument is that the mandate, or the requirement to have health insurance or pay a penalty, was taken down by the Republicans. Actually, the mandate's still there, but what they did is they made the penalty zero, and as part of the tax bill after Trump came in. The predictions, by the way, were that would do a lot of damage to the Affordable Care Act's reach. The arguments are more technical than you may want to get into, but just briefly, the Affordable Care Act has a requirement that health insurers have to issue insurance even to people with pre-existing conditions, which wasn't true before the Affordable Care Act. So there are like 110 million people with pre-existing conditions. Insurance company could say, "Oh, you've already had a heart attack, you can't have insurance." But the Affordable Care Act made that illegal. So it's called guaranteed issue. You have to issue insurance. If that were required, then what insurance companies would automatically do is say, okay, yeah, you've had a heart attack, you'd have insurance, but because you're very likely to be sicker, your premium is going to be really high. And you, Ali Bokhari, since you're so young and healthy, your premium is going to be low. And so the spread of premiums would reflect pre-existing conditions. And that would not be tenable because the people with pre-existing conditions or illness would have unbearably high premiums. So the second element of the Affordable Care Act strategy was community rating, basically, which is we're all going to be in the same pool. That you can't have that much variation. We're going to require the band of coverage costs to be narrow. Threefold is what they said. You can adjust for I think age somewhat and gender somewhat, but you can't adjust for pre-existing conditions. So that's narrowing the band of coverage. Community rating. So now you have two factors. You have to be able to get insurance, and the premiums have to be reasonably temperate, even. Well, you all are healthy young people, so what would be smart for you to do? What would be smart for you to do is nothing. Don't buy insurance. Wait for your car to hit a tree. Wait for your to break a leg playing soccer, and then right then buy the insurance. Because why would you pay while you're healthy? You have to be able to get it when you get sick, if you get sick, and you probably won't. And what that would do is pull all the healthy people out of the insurance pool, which is a formula for very high premiums. So the thought was, no, we have to do something to get you young, healthy people into the pool, and that is we're going to penalize you if you don't get into the pool, and that was the mandate. Originally, it was not that much, but it was a couple $100 a year if you didn't buy insurance, but enough to encourage people to get insurance. That was the unbreakable triad: community rating, guaranteed issue, and a penalty. The Supreme Court said the penalty was attacked in the Supreme Court, and the Supreme Court said, well, it's a tax, and that's okay. Congress can have a tax. And so that's the Affordable Care Act escaped, thanks to John Roberts' vote in about 2012. Well, the government's, the Trump administration has been at this, and now it's in the Supreme Court with the following argument. The Republicans made the penalty 0, so they did away with the mandate, and that essentially, according to the argument in the court, did away with the entire Affordable Care Act, because the whole act depends on the existence of the mandate. That's what's going to be decided November 10th. One hopes they don't go that way. It's not a logical argument. And by the way, it turns out the mandate has not made that much difference. The absence of the mandate, the insurance market has not blown up. It's done not bad. But that argument could be made, and is being made, and we'll see what they say. The issue will be called severability. Severability would be the decision about whether you can take one part of the law and essentially zero it out and keep the rest of the law, whether it takes the whole law down. That's the argument. What's going to happen? I don't know. You might say, simply put, one thing to do would be to just, gee, I don't seem to have screen sharing. Let me see. It's not letting me share my screen. What am I not doing properly? Oh, there we go.
Yep, we're set.
Okay, great. You could say, well, the fix should be easy, which is just go ahead and put the mandate back, put a penalty back in. And if the Democrats win the Senate and the House and Biden wins, I suppose that would be a possible fix. The report would say, okay, you fixed it. Maybe not, I don't know. But let me show you the Affordable Care Act briefly. This is more than you asked for, but it's a really amazingly comprehensive law. There are 10 titles in it, 10 different sections of the law, and they fall into 2 basic pots: insurance reform and delivery reform. Insurance reform has 2 parts to it: cover more people, and these are the mechanisms: Medicaid expansion, which now has happened in all but 12 states; set up the exchanges so people can buy insurance with subsidies. Here's the guaranteed issue piece, which is you can't use pre-existing conditions as a way not to offer care coverage. And kids in their parents are covered under the parents' policies now up to the age of 26. That may still apply to some of you. And then here's a bunch about better coverage, which is, this is all a bunch of word salad about things that make health insurance more complete, minimum benefits, low overhead, and so on. A massive increase in prevention benefits, and a lot that Nadia will know about with better prescription drug coverage. That's the first part of the Affordable Care Act. The whole rest of the Affordable Care Act is about delivery reform, making care better, like fostering all sorts of integrated, team-based, chronic disease-oriented care. Lots of focus on care transition, so people get out of institutions at home. All these experiments with payment, like ACOs and bundles, that are trying to get care to be much more team-based. Then there's a whole bunch of focus on quality, like better, safer care, and much more transparent with lots of data available. And here's the innovation stuff, which I thought was the most exciting part when I was at CMS, setting up the Center for Medicare and Medicaid Innovation, which has tons, like dozens and dozens of experiments on healthcare delivery going on around the country. Here's an important piece: boosting the number and the supports for federally qualified health centers, which are very important places to get primary care for people of disadvantage. All of that's at risk. If you take away the Affordable Care Act, you would have to build back on every one of those avenues. And for me, when President Obama asked me to run CMS, I was the first administrator to implement the Affordable Care Act. So a lot of what you just saw, I had to oversee. And I tell you, I wouldn't know how to take it apart anymore. I wouldn't know how to disassemble that machine. So I wish I could come up with a logical answer to the question, what do we do if they take it down? I'm really not sure. And that, for that reason, I don't think they will, but don't tell anybody I said that, okay?
Thank you. We'll make sure not to tell anybody. We get the next question we have. It's from Heidi.
Dr. Berwick, thank you so much for all of your work and for taking the time to be with us here today. Really appreciate you taking this question. The effects of COVID have shed light on the broad disparities within our society. How do we go about addressing those disparities as future physicians? And how can we eliminate racial bias in our healthcare system and build trust with our patients and communities of color?
Well, two parts to your question, Heidi. Yes, the Affordable Care Act. I mean, excuse me, the COVID pandemic has shown in boldface the nature of the gravity of inequities in society in America and the racial foundations of that. The ratios, death rates from COVID about 4-to-1, 3.5 or 4-to-1 for African Americans to whites. For Latinos, it's about this 3-to-1, 2.5-to-1. But way beyond that, the profiles of serious illness are strongly affect people of color and especially African Americans. Also, especially Native Americans. Our indigenous community is hit really hard. And to that community and to those of us who are researchers in the field, this is no surprise at all. If you'd asked us to predict, this is what we would have said would happen. Because pre-pandemic, for decades and decades, centuries, this extra risk of being in a community of color in this country has been with us. This just makes it louder and more evident, more dramatic. But it's believe me, the drama's been there a long, long time. Which is the moral determinants piece. And now, if I were African American in this country, I think I would be really angry and feel like, what did you expect? And why haven't we done something about this? So for me, it's like called the question. And building trust means building results. It means putting our money and our efforts where the problem is, and we've systematically avoided that. Now, with the murder of George Floyd and the resurgence of kind of awareness, or kind of this phase, this cycle of awareness of racism as fundamental in our country, 400 years of racism, we're talking a lot about it, but I think we still have a test to meet here about what we're going to do. And we need a strong anti-racist agenda in this country, and a really serious results-oriented attack on this problem. I do believe underneath it is confronting racism directly first. We don't name it. I don't think we can begin the repair. That's controversial because you hear from some, especially on the right, that's we're not a racist country. Well, we are, and we have to name it and get beyond that. I feel the same for the way we're treating immigrants, and certainly for Native Americans. Do you know that 40% of people on the Navajo Nation in our own West don't have water? They don't have clean water. There's no access to it. 40%. So we've done a lot. I think we need a results orientation. I served on the Biden-Sanders Unity Task Force, as I told some of you, which was I supported Sanders and Warren, not Biden originally, but I was on the task force that worked on health. You should and could look at the Biden-Sanders Unity Task Force report. It's Googleable. It's like 90 pages, so you better have a glass of wine when you start on it. But those of you who are of age, but I think I'm proud of it, because in it there is a lot of focus on equity. And I'll tell you, I don't think it's speaking out of school that to the extent I've been involved with the Biden policy formulation process, equity is present in the conversation every single day. It is relentless. And so I think maybe, cross my fingers, maybe if Biden and Harris get elected, we're going to see a serious effort. In the Biden-Sanders task force, we called for something that I hope Joe Biden will do, which is to develop at the White House level an office for an all of government approach to equity, because you can't do it just in HHS or just in anything. You're going to have to get every single cabinet department together, surrounding the problem and getting at it from all sides. We called for a presidential order, an executive order on day one, establishing that effort. It is in the Affordable Care Act, by the way. There's a section of the Affordable Care Act that gives authority for establishing such an effort, and I think we need a full frontal assault on that. To me, it's all about results. When we see this level of burden, then we have believe me, we have an index now of how serious we are about solving it. So I don't know, Heidi, if that's enough of an answer to you. By the way, I'm going to embarrass Heidi, but as Heidi knows, I'm a friend and a fan of her father, Eric, who was Surgeon General of Air Force?
Army.
Army, sorry, well, that's not a mistake you want to make. And I worked with him when he was in that position. And what he has done then and now is begin to focus on the kind of holistic view of what it's going to take to create healthy communities. And he's on the right track. That kind of investment is anti-racist if we do it right.
Thank you. I think, oh, sorry, Heidi, I didn't mean to cut you off. I think for time, we're just going to have just one more question. Apologies for everyone who submitted other questions that we're not able to get to. Dr. Berwick, Don, forgive me, I know you insisted. You mentioned restoring U.S. leadership to tackle climate change before. So this question deals with that. And we have Haley.
Hi, Dr. Berwick. So I have two questions for you. So you had mentioned earlier kind of the importance of climate change and then the unexpected roles that physicians have. And so what do you think is the best way for medical students and then us as physicians? How can we exercise our obligation and advocate best for climate action? And then my second question is how do you feel climate change impacted the COVID-19 pandemic?
I don't know the answer to the second question. I've not been asked that before. I really am not sure. There are communities that are made insecure by climate change already because they lack water, good water supply, or because of heat waves and things like that. And it's got to be that interacts with the pandemic, and that the proper care of the pandemic requires resources put into care of people with COVID, and those are already stressed communities. They may have less to offer. So, but that's a good thing. I got to look that up, Haley. Climate change itself, though, is another passion of mine. Partly my wife, Anne, she was a high-level state official in Massachusetts for many years, head of the Public Utilities Commission here in Massachusetts, Undersecretary for Energy, head of the Environmental Protection Division of the Attorney General's office. So this is her work, and I get a lot of schooling about climate. I believe it is an absolutely massive threat to the health and well-being of the planet, and we are not going to escape it in the U.S. I mentioned before climate wars, food and water insecurity, storms and weather, heat waves, and so on. And I think the consequences are phenomenal. We don't have much of a window left. I mean, there is a decade, maybe some short period of time. We better get this turned around, and we're not doing it right now. So we need to be engaged. I think from the point of view of the professions, something very interesting you might want to get involved in. In fact, Ollie and Maddie, I'm happy to help you connect. But the National Academy of Medicine had its annual meeting this week. And Victor Zhao, the CEO, declared 3 priorities during the remainder of his tenure. One is COVID, and it's the end of COVID. Second is equity, and the third was climate change. And he is devoting a ton of energy right now to setting up a bunch of activities in national academies on the health effects and the medical involvement with the climate change issue. Partly it is to decarbonize healthcare, which is about, I think it's 15% of the carbon production in our country is healthcare attributable. Maybe it's 10, but it's a substantial one. And it's quite remediable. You can all log on to the Healthcare Without Harm website, Healthcare Without Harm. And it has all sorts of analyses and education about that. But you're going to see a surge of activity in national academies around this. And I was part of production of a paper to set the stage for this, which was quite a long paper on the health, climate and healthcare. And it's worth digging into. I would suggest, I mean, one kind of weird idea, Ali and Maddie, would be to have AMSA reach out to the National Academy, to Dr. Zhao, and say, you want to help? Because I think there are ways that you probably can get involved. But we better not run away from this one. There's no place to run to.
Absolutely, we would love that. We'll definitely follow up with you for that.
The author of the lead author of the paper is an architect who was an amazing leader in the climate world, as well as another person is the head of Healthcare Without Harm, Gary Cohen. So it's Walt Vernon was the lead author of the paper, and Gary Cohen is the head of Healthcare Without Harm, and they'd make wonderful guests for an AMSA meeting at some point.
Wonderful. Well, thank you so much. We'll conclude the questions and answer session over here for now. If anyone does have any more questions, we'll take a note of them and maybe we'll send them that way. I wish we could keep going.
Me too. I'm sorry if my answers were so long.
Not at all. I especially appreciated when you were sharing the slide breaking down the structure of the Affordable Care Act. Before we all do wrap up here, taking into account this entire discussion we've had so far, and thinking about earlier what Dr. Berwick mentioned about pulling the lever this election cycle, we have a couple of quick asks and action items for everyone on the call. The first thing, make sure you go vote. If you can vote early in person, please go do that. If you're going to vote by mail, make sure you drop off the mail ballot box or send it off early, and encourage your friends and family and everyone else to vote. Some of you, all of you already hopefully already know about the Men Out the Vote campaign. The majority of medical schools who are signing up and registering people to vote. You should also know that we have a couple of hundred people who've signed up to become poll workers so that we can protect the demographic of elderly poll workers who are also most vulnerable to the COVID-19 pandemic. So as you're thinking about what you can do for Election Day, consider becoming a poll worker there. And then the last couple of items, we'll just turn it over to Maddie and Becky before we wrap up.
Yeah, thanks, Ali. Just thinking about everybody who's feeling fired up after this conversation, who wants to do something quick and to do something within the next couple of days, we wanted to offer an action that sort of corresponds to a statement that we recently released today about the current confirmation process of Amy Coney Barrett to the Supreme Court. We, as the American Medical Students Association, have taken a stand saying that we are urging no confirmation until after the inauguration, instead asking the Senate and the House of Representatives to focus, if they can, on supporting our communities with a stimulus package. So I'm going to pass along a link for y'all to use for any calls that you can make to your senators, urging them no confirmation until after inauguration. So a sample script that you can use, I'm just posting in the chat. Take a copy down, and this can just be a couple minutes during a lunch break, during a couple of minutes free. You can call your senators and urge them to vote later. And then in addition, we have another opportunity for any of you who are social media fiends to write down why you oppose the confirmation. So basically, taking a picture, and I'll post in this post in the chat, taking a picture of a piece of paper that says different reasons why we're protecting the ACA, different reasons why we are protecting healthcare. So I'll put that in the chat. And other than that, I have nothing else to add. So Ali, if you want to close it out.
Absolutely. Thank you so much, Maddie. Thank you to everyone for joining us this evening. We have a couple minutes left before the debate begins. A special thank you to Don for joining us again. I'm feeling pretty fired up. I hope you all are as well. And let's get to work.
Thank you all.
Have a good rest of your evening, everyone.
Thank you.
Thank you.
Thank you. Will you have this recording available to us somewhere so that we can review it afterward? Because I apologize, I had an emergency, so I was late to the